So yeah, welcome back. We are back again with the MCQs. So I will start discussing. So the first question is, what is the most common injured part of the spinal cord? And the options are lumbar spine, cervical spine, thoracic spine and sacral spine. So yeah, I will repeat the question once again. The most commonly injured part of the spinal cord is lumbar spine, cervical spine, thoracic spine and sacral spine. So yeah, if anyone wants to answer this, most common injured part of the spinal cord: lumbar, cervical, thoracic and sacral spine. Yeah. Okay, the answer here is, if no one wants to answer, the answer here is, it's the most commonly injured part is of the spinal cord is cervical spine. Yeah. Basically, cervical spine accounts for about 60% of the adult spine injuries, and the most common is C1 to C4. And injury to C1, C2 complex accounts for around 19 to 25%. Yeah. Then it is followed by thoracolumbar and thoracic spine. So yeah, the most common is cervical spine injury. So yeah, next we have, okay, then what will be the expected number of individuals among a group of 100 people taken for the study whose BP will be below 120 mmHg? Basically it's a PSM. If you want to answer, the options are 25, 50, 99.7, 95. I will repeat once again. See, the systolic blood pressure of the normal people between the age of 25 to 27 years was taken, and a mean of 120 mmHg was found. So the question here is, what will be the expected number of individuals among a group of 100 people taken for the study whose BP will be below 120 mmHg? And the options are 25, 50, 99.7, 95. So basically they have just given rounded off, but it's very simple. The answer is very simple. The options are 25, 50, 99.7 and 95. Anyone would like to answer this? Okay, I think, yeah, okay. So yeah, 50 is the right answer. Yeah. See, a normal distribution, 50% of the values lies below the mean. That is the common. That is below the mean. It will be 50. So in this scenario, 50%, that is 50 out of 100 people will be a systolic BP of less than 120 mmHg. So it's a simple question, but it's a long question. That's why you are confused. Next question we have, which of the following operations has the highest long-term cure rate in a genuine stress incontinence? And the options are bladder buttress operation, Marchetti Kranz operation, colposusception, vaginal sling operation. I will repeat the question. Which of the following operations has the highest long-term cure rate in genuine stress incontinence? The options are bladder buttress operation, Marchetti Kranz operation, colposusception and vaginal sling operation. So anyone? Basically, you have to tell the gold standard or the treatment of choice for this stress incontinence. Okay, the answer here is, if anyone, okay, the answer here is D. That is the vaginal sling operation, which has the highest cure rate. That about 90%. 3. No, it is not colposusception. It is the fourth one. That is vaginal sling operation, which has the highest long-term cure rate. That to more than 90%. Okay, next we have, and isolated prolongation of prothrombin time was seen in a patient with chronic liver disease. What does this suggest? Factor 7 deficiency, factor 8 deficiency, factor 12 deficiency or factor 11 deficiency. So basically it's there is a prolongation of PT, and that too it was seen in chronic liver disease. So what does it suggest? Factor 7, 8, 12 and 11. Which factor deficiency will you see? You can guess at least. When there is isolated PT prolongation. 7. Yeah, the answer is 7. Isolated PT prolongation suggests that there is a factor 7 deficiency and it can be inherited or acquired condition. Acquired as in this case it is a chronic liver disease. So yeah, it is factor 9 with isolated PT prolongation. Next we have, which criteria is used to select patients for microsatellite instability testing? The options are Amsterdam criteria, revised Amsterdam criteria, Better criteria, Lynch criteria. So which is the criteria used to select patients for microsatellite instability testing? You should know this for what is microsatellite instability testing, and options are a bit Amsterdam criteria, revised Amsterdam, better criteria, Lynch criteria. Basically, microsatellites are the part of DNA. So if you want to know the microsatellite instability test, which criteria will you use? Okay, see what they have given is microsatellites are the regions of repeated DNA that changes in length when mismatch repair is not functioning. Yeah, this we know. But see, defects in the mismatch repair genes lead to microsatellite instability will be there. So that's why which criteria we have to do? Revise Amsterdam? No, we are not using it. The answer here is better the criteria is used to select patients for microsatellite instability testing. Next we have a 32-year-old man comes to you with fever with chills and seizures are there. On examination, BP was 70/50, labored breathing was present, routine blood investigations were HB 4.8, ABG was done and pH was 7.21. Findings in the peripheral blood smear are shown below. Which of the following is a drug of choice for this condition? So basically the pathological picture they have given, it's okay, the picture has this, you can see. So the picture has trophozoites in the erythrocyte, in the RBCs, and which are binucleate. Okay, this now can tell if it is trophozoite in the RBCs, what will be the diagnosis. So yeah, the options are chloroquine, quinine, artesunate or artemether. So what is the drug of choice for this condition? So the scenario is fever with chills with seizures, 70/50 BP, labored breathing, routine examination, that is HB is 4.8 and pH was 7.21. The first diagnose, what is the condition? So it's a malaria, we all know because of trophozoites in the RBC, but which type of malaria? And that too, what is the drug of choice for that malaria? Chloroquine, quinine, artesunate or artemether? What is the drug of choice for artesunate? Yeah, artesunate is the right answer. See, basically this is a condition of severe complicated falciparum malaria, and the drug of choice is artesunate, and whatever was there, it's it's caused by falciparum. This characterized by hyperparasitemia, hyperpiracia, acidosis, respiratory distress, bleeding manifestation, cardiovascular collapse, renal failure, and cerebral malaria will be there. Okay. Cerebral malaria. It should be treated with intravenous or intramuscular artesunate for at least 24 hours. Once the patient recovers and can tolerate medication, oral ACT for 3 days is recommended. Next we have identify the instrument. Okay, this I cannot show because the instrument is it's a mouth gag, Doyne's mouth gag instrument. So you have to see by yourself only. It's using the intraoral surgery and all. It's a gag for tonsillar surgery. Tonsillectomy use a mouth gag. The next question. So which of the following is the most common cause of blindness in India? This I know you know. It's a refractive error, cataract, diabetic retinopathy or trachomatous corneal opacity. So most common cause of blindness in India: refractive error, cataract, diabetic retinopathy or trachomatous corneal opacity. This answer: common cause of blindness in India: refractive error, cataract, diabetic retinopathy and trachomatous corneal opacity. Yeah, cataract is the right answer. It is the most common and accounting for about 66.2% of total cases. Next we have a 40-year-old man is there who complains of pain in the right hip while walking up the stairs. So he has been on long-term steroid therapy for rheumatoid arthritis. Physical examination and radiograph of the hip are unremarkable. So what is the best imaging modality for this condition? And the options are MRI, CT scan, bone scan, PET scan. So yeah, it's a 40-year-old with complaints of pain in the right hip while walking up the stairs. He has been on long-term steroid therapy for rheumatoid arthritis and there is no remarkable findings on examination and radiograph. So what is the best imaging modality for this? So first, diagnose this condition because without diagnosis you cannot tell. Yeah, Bone scan. No, bone scan it is not there. The answer here is MRI scan. Because the case here is avascular necrosis of the femoral head. How? Because it is right hip, it's there while walking up the stairs, and steroid therapy for rheumatoid arthritis. Because the long-term steroid use, as you know, it will cause AVN. It's a complication for AVN. So yeah, MRI allows identification of avascular necrosis of femoral head in earlier stages and also determined at that stage. So yeah, so MRI is the best invasive modality for this condition because it's the AVN, avascular necrosis. Next question we have: which of the following is not seen in a patient with atypical CML? Options are Philadelphia chromosome negative, basophilia greater than 10%, blast cell less than 20%, and neutrophil precursors greater than 10%. So which is not seen in a patient with atypical CML? Philadelphia chromosome negative, basophilia greater than 10%, blast cells less than 20, or neutrophil precursor greater than 10. Which is not seen. Anyone? Okay, the answer here is if basophilia. Yeah, the answer is second one is, say, basophilia greater than 10% won't be there in atypical. It can be there, but in atypical it won't be there. It will be less than 2% of total WBCs. And what is atypical CML? It's a leukemic disorders having features of both myelodysplastic as well as myeloproliferative. Yeah, features at the time of diagnosis. Okay. So Philadelphia chromosome as negative, it will be there. Blast cell less than 20%, it will be there. Basophilia less than 2% will be there. Neutrophil precursor greater than 10% will be there. Okay. Next we have you are investigating an outbreak of diarrhea. You find out the etiological agent causes stack brick formation on Hep2 cells as shown below. What is the likely organism? So it's a diarrhea outbreak. An etiological agent causes stack brick formation in the Hep2 cells. So what is the likely organism? So they have given all the types of E. coli, that is enteroaggressive, enterohemorrhagic, enterotoxigenic, or enteroinvasive. So to remember, this stack brick pattern is seen in which E. coli, stack brick pattern of adherence on Hep2 cells is caused by which E. coli? Enteroaggressive, enterohemorrhagic, enterotoxigenic, enteroinvasive. Anyone? Okay, the answer here is it's A, that is enteroaggregative is the answer. Because stack brick pattern is seen in the case of enteroaggregative E. coli, and it has been associated with persistent diarrhea, and it is mediated by aggregative adherence membrane. Yeah, EHCC. Enteroaggregative it is E. coli, it is not enterohemorrhagic. So to remember, the stack brick pattern is seen in which condition. Next, we have a 30-year-old female presents to the OPD with fever, lower abdominal pain, purulent vaginal discharge. On examination, on vitals are stable, and per vaginal examination reveals a lower abdominal and cervical motion tenderness. Yeah, what is the best option for this? So I'll repeat, it's a 30-year-old female comes to the OPD with fever, lower abdominal pain, purulent vaginal discharge. On examination, you see the vitals are stable, and per vaginal examination reveals a lower abdominal and cervical motion tenderness. What is the best treatment option for this for her? So the options are, first you can give it is a single IM injection of ceftriaxone 250 mg with oral doxycycline and metronidazole for 14 days. Second option is single IM injection of again ceftriaxone 150 mg with oral metronidazole 400 mg for 7 days. And third is oral doxycycline 100 mg BD with oral metronidazole 400 mg for 7 days, or the last option is oral ofloxacin 200 mg BD with oral metronidazole 400 mg for 14 days. Now you tell which is seen. Fever, lower abdominal pain, cervical motion tenderness is there. So what will you diagnose first before the treatment part? What is the condition? Fever, abdominal pain, cervical motion tenderness. Okay, the answer here is PID. The condition here is PID, and for PID, the best treatment that is the OPD treatment, because the patient, they have mentioned, comes to the OPD with this. So with OPD, if you have to give, that is the first answer, that is single IM injection of cetirizine you will give 250 mg with oral doxycycline and metronidazole for 14 days you have to give. Yeah, A is the answer. So it's outpatient that, yeah. Suppose it is a PID in hospitalized patient, then you will give this cefotaxime, that is cetirizine 2 gram IV 12 hourly per doxycycline plus doxycycline 100 mg BD orally for 48 hours. Then followed by again oral doxycycline 100 mg plus minus metronidazole 400 mg for 14 days. You okay? Don't remember that. The same outpatient patient comes to you, you have to give single IM cetirizine, that is 250 mg, and plus oral doxycycline you will give, and metronidazole 14 days you will give the patient. Next we have a researcher developed a drug X that functions as an IL-17 receptor antagonist for the treatment of psoriasis. Identify the drug X. Options are secukinumab, izokizumab, prodalizumab, or infliximab. So again, a researcher is there who developed a drug X that functions as an IL-17 receptor antagonist for the treatment of psoriasis. Identify the drug X. Secukinumab, izokizumab, I am not able to spell it. It's a prodalizumab or infliximab. Anyone? I haven't heard also. Anyone wants to try at least? Okay, the answer here is it's a simple answer. It's a prodalizumab. That is the brodalumab. Sorry, brodalumab is the more close antibody against the IL-17 receptor, and that's what I have to remember. It's a biological drug that is used for cases of severe psoriasis as well as psoriatic arthritis. That's all. Another, that is the first A and B, that is secukinumab and izokizumab. It's binds to IL-17 and prevents it binding to receptor. They are considered as IL-17 neutralizers. So we are talking about antagonists. Antagonist is, that is prodalizumab. You have to remember this. Next question. What is the angle subtended by the optotype on the second line of Snellen's chart when viewed from a distance of 6 meters? It's opthal. So the options are 5 meters, 5 minutes of arc, 30 minutes of arc, 25 minutes of arc, or 6 minutes of arc. I will repeat. What is the angle subtended by the optotype on the second line of Snellen's chart when viewed from the distance of 6 meters? 5 minutes, 30 minutes, 25 minutes, or 6 minutes? Yeah, on the second line. Okay. Okay. I'll write the answer. The answer is B, that is 30 minutes of the arc of the second line. It is like that. So the second line, that corresponds to a distance of 36 meters, and when viewed from a 6 meter distance, it is denoted by visual acuity of 6 by 36. So it's a formula again. It's like AMR equal to 1 by visual acuity. So if you don't know the formula, it won't be. It's like 1 by 6 by 36, and then again 36 by 6, that is 6 meters of arc. So yeah, without formula you won't be. That is MAR, that is it is equal to 1 by visual acuity. So visual acuity is 6 by 36 as second line. Next we have, it's a 35-year-old male man was diagnosed to have an heterozygous sickle cell trait. What will be the approximate percentage of HBS in this patient? 40%, 60%, 50%, 30%. I will repeat. It's a 35-year-old man diagnosed to have an heterozygous sickle cell trait. What will be the approximate percentage of HBS in this patient? 40%, 60%, 50%, or 30%? Anyone less to try at least? It's a heterozygous sickle cell. Okay, the answer here is the answer here is, that is the first one only, that is the 40%, because in heterozygous sickle cell trait about 40% of the hemoglobin is HBS, whereas rest is HbA. Whereas the same thing, if you consider it is in heterozygous HBSC head to head, I guess it will be HBS will 50% or HBC will 50%. Yeah, first is the right answer, that is the 40%. So it's a heterozygous sickle cell trait, 40% will be HBS, others will be HBA. HBS and idea. Okay, next question, we have a nitrous oxide cylinder is there of at 100%, 50% and 25% volume respectively. Would show the pressure of in PSI of total 750, 750, 750, 2200, 2200, 2200, 750, 375, 62, 162.5, or 2200, 1100, or 550. So it's a nitrous oxide cylinder with 100%, 50% and 25% volume respectively. Would show the pressure in PSI of total. What I told you, 750, 750, 750, 2200, 2200, 2200, 733, 75, 162.5, or 2200, 1100, or 550. Anyone wants to try? That's an easy question. What will be the volume? Okay, see, I'll tell the answer. Yeah, the answer is first one only, that is 750, 750, 750. Because see, the cylinder is of air, but nitrous oxide, what we use is of liquid. So it will stay in liquid at whatever constant, whatever volume you do, whatever volume cylinder it is, but it will be at liquid composition. So at 750 psi pressure only it will be stay at liquid. Otherwise it won't be at liquid. So the answer will be it's all 750, 750, and 750. Yeah, it's on the liquid pressure. Hence it will read full as long as there is liquid in the tank. After which pressure falls into the cylinder exhausted. Yeah. The answer is that 750, 750 and 750 in liquid form it will be there. So at any volume it will be 750. Next question, when does the parachute reflex disappear? At 3 months, 6 months, at birth, and reappears at 9 months and never. Yeah, it's an easy question. If parachute will be, okay, we'll repeat. When does the parachute reflex disappears? 3 months, 6 months, at birth, and reappears at 9 months and never. Yeah, at least one should answer this. Okay, I will tell the answer. Yeah. See, the parasite reflex will be there for your entire life. Because whenever you fall, also, never. Because whenever you fall, also, you see that both hands are outside. Sorry, both hands are outside, and you fall from a height. Also, then also your parasite reflex will be seen. And in children, it is like its onset is in at 7 to 8 months, and it is fully developed by 10 to 11 months, and it remains throughout the life. No, it is answer is never. And it can be evoked by holding the infant's neck and then suddenly lowering the infant as if he or she is falling. The arms will be spontaneously extended to break the infant's fall. Next question. On an IQ test, a 9-year-old child was found to only have a mental age of 3 years. What category of intellectual disability does the child belong to? Options are mild intellectual disability, moderate, severe, or profound. So IQ test, 9-year-old child, and but 9-year-old child is there, but the mental age was found to be 3 years. So what category of intellectual disability we consider? Mild, moderate, severe, or profound intellectual disability? Anyone? There is a formula for this, if you remember. Okay, I'll tell the formula, then you can answer. See, the formula is mental age by chronological age into 100. So now you can tell it is mental age is how much? 3. And what is the chronological age is 9. So it is 3 by 9 into 100. So yeah, the answer is the answer will be 33.33, and that comes under, that is the severe, that is 22 to 34 is the severe mental retardation. So yeah, so it's a 33.3 that comes under severe mental retardation. Answer is C. Next we have a patient who is diagnosed with congestive heart failure. So which of the following is not prescribed to prevent progression and revert cardiac remodeling? Beta blocker, AC inhibitor, digoxin, aldosterone antagonist. I'll repeat. A patient is there and he is diagnosed with congestive heart failure. And which of the following is not prescribed to prevent progression and revert cardiac remodeling? Options are beta blocker, AC inhibitor, digoxin, or aldosterone antagonist. It is not prescribed to prevent progression and revert cardiac remodeling. Anyone like to answer this? Okay, the answer is C. That is the digoxin is the answer. See, there is no role of this in preventing the cardiac remodeling, and what it does is basically what digoxin does. You all know that is contractility will be increased. Cardiac muscle will be more contractile if we give digoxin, and it is indicated in for symptomatic management of congestive heart failure. So it is not for remodeling. So beta blocker, AC inhibitor, and aldosterone antagonist we can give, but no, digoxin we cannot give. So that's the question. Next we have how many grams of NaCl make 1 mole of NaCl? 58.5, 56.5, 57.5 or 50.5. This is a biochem, anyone can try at least. How many grams of NaCl makes 1 mole of NaCl? 58.5, 56.5, 57.5 or 50.5. Okay, the answer here is, if no one wants to answer, it is A only, that is 58.5. Basically you have to divide, it's a molecule, Na and Cl. So in biochemistry or in chemistry you might have known Na is that 23 and Cl is 35.5. No, it's not 56.5, it is 58.5. Because see, 1 mole is equal to the weight, that is what is the weight, it is Na is 23 and Cl is 35.5. So it is 26 plus 35.5, that is 58.5 is the right answer for this. So 1 mole is equal to the weight, that is how many grams. So if you want to know more, it is what they've written is each mole consists of 16 to 10 power 23 molecules, and the molecular weight of a substance is the ratio of mass of 1/12 of the. That is not required. But remember that 1 mole is equal to the weight of that molecule, that is Na plus Cl. Next we have a young man presents with hearing loss and tinnitus. Historical image they have given, and what is the diagnosis? So in the historical image I will just tell you, it shows Veracay bodies. Veracay bodies is seen in which condition you have to remember. Okay, young man, it is the hearing loss and tinnitus. Histological image is given, what is the diagnosis, and histological image shows Veracay bodies. Options are neurofibroma, schwannomas, leiomyoma or rhabdomyoma. So I will repeat, it is neurofibroma, schwannoma, leiomyoma or rhabdomyoma. So Veracay bodies are seen in which condition? Anyone can tell? Okay, the answer is schwannoma. Schwannoma is basically, it is acoustic neuroma. You all know that acoustic neuroma is what? It is a benign tumor of the cranial nerve, right? That is the auditory nerve, you can tell. So it's basically Veracay bodies are seen in the schwannomas. And what is schwannoma? Told what is schwannoma, and it is mostly seen in 60 to 40 to 60 years. And it is progressive unilateral hearing loss and tinnitus. And fifth cranial nerve is the earliest cranial nerve to be involved. Other nerves are also involved in that. So bilateral schwannomas are seen in patients with neurofibromatosis type 4, type 2 with a mutation of NF2 gene on chromosome 22 leading to loss of expression of myelin. All that you have to remember. I cannot tell that. Okay, a resident is there who is evaluating a patient who presents with acute onset of chest pain and dyspnea for pulmonary embolism. Which of the following imaging tests should be performed to confirm the diagnosis? Doppler echocardiography, CT pulmonary angiography, ventilation perfusion scan of lungs, or MR pulmonary angiography. I will repeat, it's a patient with acute onset chest pain and dyspnea and for pulmonary embolism. So which of the following imaging tests should be performed to confirm the test? Doppler echocardiography, CT pulmonary angiography, ventilation perfusion scan of lungs, or MR pulmonary angiography. For pulmonary embolism, what you will, anyone? I think it is, so Anyone likes to answer this? Okay, what is the investigation of choice for pulmonary embolism? That only they are asking. So yeah, the answer there is, yeah, it is B. That is CT pulmonary angiography. It's a principal imaging choice. So I thought MR, but it is not. It is not MR. It is CT. And why? Because MR may detect large proximal P, but it is not reliable for smaller segmental and subsegmental P. So yeah, because that's why you have to give. No, it is not MR, because that's what I told, that it won't detect. It may detect large, but small P you cannot detect. So the answer is CT pulmonary angiography. Next we have D. Quervain's disease classically affects orthopedic question. D. Quervain's disease classically affects extensor pollicis longus and abductor pollicis longus. Second option, extensor pollicis longus and abductor pollicis brevis. Third is extensor pollicis brevis and abductor pollicis brevis. Fourth is extensor pollicis brevis and abductor pollicis longus. Yeah, you can tell this answer if you know what is D. Quervain's disease. It's affects which tendon affects. Anyone? Yeah, it's prominent among females, pregnant women. Okay, the answer is D. That is the extensor pollicis brevis and abductor pollicis longus is basically D. Quervain's disease. It affects. It's a tenosynovitis, tenosine tenosynovitis of extensor tendons of the first dorsal compartment, that is the extensor pollicis brevis and abductor pollicis longus. So what is the treatment? The treatment is, yeah, D is the right answer. The treatment here is basically it's treated medically. Only a few require surgical release of the first dorsal compartment. So yeah, you got that. It's D. Last question. While performing a modified radical net dissection, the surgeon prevents the structure marked below. Which of the following is supplied by this structure? Now, how can I tell you this? Okay, I can give you a hint at least. Okay, it's while performing a modified radical dissection, the surgeon preserves a structure marked below, and which of the following is supplied by this structure? And the structure which is saves is spinal SSI nerve. Yeah. So now, okay, the question is simple. Which of the following is supplied by this structure? That is, spinal SSI nerve supplies which of the following? That is diaphragm, trapezius, skin over the parotid gland, or supraspinatus. It's an anatomy question. Spinal SSI muscle supplies which of the following? Diaphragm, trapezius, skin over the parotid, or supraspinatus. Anyone likes to answer this? Okay, I'll tell the others and you can at last you can tell the answer. See, anyone, diaphragm is supplied by? Okay, diaphragm, phrenic nerve supplies diaphragm. Then we have C, that is the skin over parotid gland. It is supplied by retroauricular nerve. Then D, that is supraspinatus. Supraspinatus is supplied by suprascapular nerve. And yeah, the answer which we are discussing is trapezius. Trapezius muscle is supplied by spinal SI nerve, and it enters through the posterior triangle, passing through the sternocleidomastoid muscles and then in an oblique direction within the triangle to supply the trapezius. So yeah, you have to remember the muscle supply as well as the nerves. So yeah, the answer is trapezius. No, one more question is left. Sorry. Last. It's, I don't know if you've been knowing or not. It's a nagelejam is used in the treatment of what? Nagelejam is used in the treatment of Lamin syndrome, Morquito's disease, Wong-Gilkins disease, or Niemann-Pick disease. You can just guess it. I think most of you will not know. Okay, I will repeat again. Nagelejam is used in the treatment of Lamin syndrome, Morquito's disease, Wong-Gilkins disease, or Niemann-Pick disease. Anyone? Okay, I will only tell it. The answer is the first one. That is the Morquito's-Lamin syndrome. It is used in the treatment, that is nagelejam. And what is the Morquito's-Lamin syndrome? It is caused by a deficiency of aryl sulfatase B enzyme, whose gene locus is on chromosome 5. And nagelejam is an enzyme that is used for treatment. Yeah. And preservation of intelligence is the feature of this syndrome. Yeah, that's all. So yeah, we completed today 25 MCQs. Okay, it's done. Thank you. Take care.